that's still home. So yeah, as Ethlyn's talking, I'm thinking of the mountain out the window.
Well, I was ready for a trip to speak at University of Washington at the end of March, and obviously that didn't happen. So no.
My sister's, it's Swedish.
Oh, okay. Yeah, so many of those hospitals are now merging and yeah.
Right.
Looks like, oh, we're right there.
Good evening. I'd like to welcome everyone to the COVID-19 Vaccine Facts, Not Fear Vaccine Safety Webinar for Healthcare Providers for December 22nd, 2020. My name is Donald Moore, and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator-asked questions of the expert panelists and 15 minutes of Q&A from attendees using the chat functionality. Attendees who joined by telephone who have questions should send their questions to eprtraining@vdh.virginia.gov. Your feedback is requested regarding the panel discussion webinars. Please complete the survey. The link is provided in chat. Your experts panel for the evening is as follows. Dr. Norm Oliver, Commissioner, Virginia Department of Health. Dr. Kosti Sifry, Professor of Medicine and Director of Hospital Epidemiology, UVA Health, Division of Infectious Diseases, Co-Chair, VDH Vaccine Advisory Workgroup, Safety and Efficacy Subgroup. Dr. Tyson Bell, Assistant Professor of Medicine, UVA Health, Division of Infectious Diseases, Director of Medical Intensive Care Unit. Dr. Jose Munoz, Professor of Pediatrics, Division of Infectious Diseases, Children's Hospital of Richmond. Your moderator is Dr. Ethelene Gibson, Associate Professor of Nursing and Director, Gerontology Center of Excellence, Hampton University. Now I'll turn it over to Dr. Gibson.
Thank you so much. It is really great to be here with everyone this evening, and especially my fellow colleagues from the nursing community. We will be addressing some questions, and we do hope again that you put your questions in the chat box. So let's get started. I'd like to start with Dr. Oliver, and I'd like to have you address a couple of questions surrounding the numbers of COVID-19 infections. Can you give a brief overview of where we stand in terms of numbers of COVID-19 infections in the U.S. and specifically in the Commonwealth of Virginia?
Thank you very much, Dr. Gibson. Can you hear me okay?
Yes.
Great. Well, I'll just go straight to the Commonwealth of Virginia, where, like the rest of the country, we're seeing a very marked increase in the number of cases. Anyone who's been following this knows that the number of cases that we're experiencing now are actually quite a bit larger than the number of cases that we were seeing back in April or May of this past year. Currently, we're seeing around 39 cases per 100,000 in the state of Virginia. And that puts us well above our sort of the point that we'd like to be in. In that case, incidence has been rising for the last couple of months. We're seeing increases again following the Thanksgiving holidays, and probably will continue to see increases as we go through the rest of the December holidays, and can expect this trend to continue into January and even February. The number of cases, for example, just reported yesterday was close to 3,600 new cases, and we've been averaging well over 4,000 cases a day, and every case has several contacts. So we're looking at a pretty significant spread of the virus in the community, what we would call widespread community transmission, and that's true across the entire Commonwealth. It's particularly high in the far southwest of the state, where what we've seen has been somewhere on the order of about twice that number that I just gave you. The case incidence in far southwest Virginia is currently around 75 cases per 100,000. So that's about twice what it is across the rest of the state. A lot of this is driven by church gatherings, even small gatherings, more than 10 people in private gatherings in the home, that sort of thing. And this is the reason why we've been encouraging people to limit those social gatherings. The most important thing we can be doing right now to slow the spread of the virus is to wear our masks, watch our distance, and wash our hands as frequently as we can. That will help. Of course, there's light at the end of the tunnel here with the advent of the COVID-19 vaccines, which we'll get into more in the rest of this discussion. So those are the numbers. We got a vaccine. That's light at the end of the tunnel. We're very hopeful about that. But the virus is still here and spreading quite rampantly throughout the community. So we both need to get the vaccine into the arms of people across the state, but also protect ourselves by wearing our masks and washing our hands and watching our distance.
Thank you so much, Dr. Oliver. Our next question is actually going to go to Dr. Sifry, and we are going to address some of the questions that have been coming up, not only in the nursing community, but across the Commonwealth in regards to vaccine safety and the emergency use authorization. So Dr. Sifry, would you be able to address the following two questions? Can you tell us a little bit about vaccine trials, how many people there were in those trials, and what is the efficacy data? And then after that, just explaining a little bit about the FDA emergency use authorization and what makes this process a little bit different than the usual process of authorization.
Great questions, Dr. Gibson. So we'll go ahead and first start with the trials themselves. So we're going to talk about two different vaccines that I think we're now all familiar with, the Pfizer vaccine and the Moderna vaccine that have received this emergency use authorization, EUA authorizations in the previous 2 weeks. The vaccine trials for these products were large. They're very large, larger in many instances than other vaccine trials that have, for products that have come to market recently, like Shingrix. So the Moderna vaccine had a total of 30,000 participants that were in the trial. For the Pfizer vaccine, it was over 44,000. A little bit fewer taking a look at the efficacy outcomes, but in terms of the safety outcomes, over 44,000. What was found with their efficacy and safety profiles? In terms of safety, and I think that's the first thing that you have to, overcome with any type of vaccine trial, they were found to be very, very safe in terms of side effects. We'll get to hear from, I think, 3 of us on the panel who have received the vaccine thus far, at least. It's very, very mild symptoms, local arm pain and discomfort, particularly with the first shot. There's some discussion of sort of reactogenicity, sort of a little bit more achy and pains, maybe headache, fatigue, low-grade temperature is possible. Those tend to occur after the second dose and tend to be more likely to occur if you're younger compared to if you're older. But both clinical trials have shown that they are very far and away well-tolerated vaccines with no significant signal in terms of severe adverse events or safety concerns. So that's good news, clearly. And as I said, the first hurdle, the second part is really critical, and that's its efficacy. And what both vaccines have shown is pretty equivalent efficacy, 95% protective against symptomatic COVID infection. And as exciting and as important, also that level of efficacy in terms of severe COVID infection. COVID infection, for example, that lands you into the intensive care unit, such as the one that Dr. Bell is the medical director for. So very safe and very effective. So those are the sort of the broad outlines of these trials, and we can talk more about them a little bit later as we talk about other things. But I think the next question about what is this emergency use authorization is really important and rather confusing. So what an EUA, emergency use authorization, is simply the ability to use a medication before it's received full licensure. And why is that? Why was that done in this case? Well, there are a couple tenets that need to be fulfilled in order for an EUA to be granted. So the first thing is that you need to have a medical condition of significant public health concern. And as Dr. Oliver just went through, there is no better example of medical concern of something that is causing problems for the health and welfare of our society and the people in it than COVID, clearly. So clearly meets the criteria of medical concern. The second issue is that there needs to be a lack of other medical therapies. And while we have some medical therapies that are available for significant COVID infection that leads you into the hospital, we really don't have mechanisms to pharmacologically to control disease. What we do have public health measures like masking and keeping distance that Dr. Oliver talked about. And then the final thing does the product that's available, is it safe and is it effective? And that's just sort of what I went through. It is safe and it is effective, both of these vaccines. The big difference with an EUA authorization is the time of follow-up. So we have the safety profiles and understanding of how well this vaccine works for 2 months on average after people receive it. And it, as I said, it appears outstanding. But we don't have the long-term efficacy. We don't know, for example, how long immunity lasts and those types of questions. Those will come with time. And that will be the big difference between an EUA authorization and full licensure, which would occur, later down the road, perhaps 6 months, a year from now.
Thank you, Dr. Sifry. So we've talked about the numbers, and we've now talked a little bit about the vaccine and how it went through part of the process. Let's talk about the vaccine mechanism of action. And those questions will be addressed by Dr. Bell. So Dr. Bell, I have a few questions, and I'm sure you'll probably wrap all of them up together. Many people have been asking, they want to have a better understanding of messenger RNA. They also would like to know, because we talk about messenger RNA, is there a difference if I receive the Pfizer vaccine? And then when it's time for my second dose, should I also receive the same vaccine? Is there any difference in that messenger RNA? Is it interchangeable? And then briefly, can you clarify the key differences between the two vaccines manufactured currently by Pfizer and Moderna? Dr. Bell?
All right, so easy ones. I like that. Just kidding, but thank you for having me. And really, what we have to do in the midst of a crisis that has a potential light at the end of the tunnel is really bring the public up to speed and our patients. So I'm happy to serve that role. I want to talk a little bit about what messenger RNA is. It's the new buzzword of microbiology. But if we just start from, going back to biology class, messenger RNA is basically a recipe. The recipe that our body cells use in order to carry out the business that our body does. So for instance, if we were to eat a meal and our pancreas submitted enzymes or secreted enzymes to help us digest that meal, messenger RNA is kind of the recipe and the message that sends out to our body to make those enzymes that we need to carry out that business. Now, normally, the DNA that houses our genetic footprint, it is who we are, is housed in a nucleus, and that's kind of the temple of the cell. It's kind of like if you go into a bank, the nucleus would be the safe deposit box. That area, very protected, hard to get into. Got to know what's going on. Messenger RNA is in our bodies normally made in a nucleus and then goes out of the nucleus and goes out into the branch area of the bank, and that's where the normal business of our cells takes place. Now, the one difference with the messenger RNA that the vaccine gives us is that it does not enter the nucleus. So it goes into the branch and carries out the business, but it doesn't go into the safe deposit box. So it does not interact with our DNA, does not integrate, and that's been a major concern from our patients that this could potentially change our genetic code. That's simply not the case because it does not have the keys to the safe deposit box. All right. Now what does it do? So the recipe actually gives instructions for how to make proteins. And in this case, the protein that the messenger RNA is making or instructing our body to make is the spike protein. Researchers from years ago, over a decade ago, studying SARS and MERS understood that if you wanted to make a vaccine against the coronavirus or a coronavirus, that the spike protein was a very good target to do that. So this research was already being done, but kind of the last step to get along the way was the delivery device, and that's kind of what was able to be accelerated with the EUA and the mass investment from Operation Warp Speed. But I digress a little bit. So what the messenger RNA vaccine does is teaches our bodies how to make this spike protein, which by itself is completely harmless. When it is attached to a coronavirus, of course, it is harmful because that's what it uses to get inside of our cells. But when it's by itself, it's just a little protein. Now, our body does a really good job of recognizing friend versus foe. So when it sees a spike protein, this is something that it is presuming you haven't been infected before. It's something that you've never seen before. And your white blood cells take it and present it and say, hey, this is new. What is this? Your T cells will help induce an immune response, and then you make antibodies to it. And the antibodies will attach to it, to different parts of it. And that helps your body recognize the fact that this is a foreign invader. We need to get rid of this. So it actually teaches your body to make antibodies to the spike protein so that later, if you get infected with an actual coronavirus that has its actual spike proteins that can cause injury, your antibodies are blocking the interaction between the coronavirus and uptake into your cells. And so what that means is that you have definitely a decrease in your symptoms, and Dr. Seep talked about 95% efficacy. There's a possibility that it could decrease spread, but we definitely need more data before we can make that sort of claim. But that's why this has been such a good development. So that's basically how the messenger RNA vaccine works. The issue about and we now have two available, can you use one and then the other? The firm recommendation from FDA and ACIP is that we do not use these interchangeably. They are based on the same technology and a similar delivery platform, but they weren't studied in this way and they should not be administered this way. So absolutely, under no circumstances should we be mixing and matching the vaccines. So that one was relatively easy. Now, the key differences between the Pfizer and Moderna vaccine, so, we can get very, very deep on this, but I can give you kind of a few highlights as to what actually is different between the two. So one is the storage requirement. That's been one of the big things that the Pfizer vaccine has been a challenge for because it does require much colder storage than a Moderna vaccine. We're talking negative 70 degrees Celsius, which is far colder than your neighborhood pharmacy, your neighborhood clinic, or even a small facility may have. So places like the University of Virginia and large institutions that have access to this will have a much easier time having the Pfizer vaccine. The Moderna vaccine is able to store between 2 and 8 degrees Celsius, which conventional freezers can kind of handle. So that's one major difference. To go back to talking about clinically about the two vaccines, they do have slightly different age indications. So the Pfizer vaccine, which opened up the children kind of towards the later stages, is approved for 16 and up. So teenagers who can drive can receive this under the EUA. The Moderna vaccine is 18 and up, so these are going to be all adults. The dosing schedule is also slightly different. The Pfizer vaccine is spaced by 21 days. The Moderna vaccine is spaced by 28 days. The dose of the vaccine is also slightly different. The Pfizer vaccine is 30 micrograms. The Moderna vaccine is about 3 times that at 100 micrograms, so a little bit of a larger dose. But again, they achieve similar efficacy. And then, one key difference that has a big sort of effect on distribution is the minimum order that you're able to procure as a facility. So for Pfizer, the minimum order is 975, which is certainly not an issue at a place like the University of Virginia. We have tens of thousands of them, or many thousands of employees. In the Moderna, you can order 100 doses at a time. Now, the reason why this is important, there was a news story recently that Meharry Medical College in Nashville, Virginia, actually was skipped over for the Pfizer vaccine initial allocation. Because they are a smaller facility, they're certainly on the front lines of providing a lot of COVID care and high-risk population, high-risk staff, but they were passed over because they were a smaller facility and did not have 975 employees to vaccinate. So, their president and CEO was actually on the advisory committee for the FDA and had to fight to get doses to his facility. So it does have real world implications and consequences, those differences. And then, this actually became important for the Pfizer vaccine, but the vials are a little bit different. So the Pfizer vials were licensed or authorized for 5 doses. And we noticed, a lot of the pharmacists noticed early on that it looks like there were more liquid left over and we could actually deliver more if we needed to, but it wasn't authorized for that, so it had to be trashed. But now Pfizer allows you to do a 6th dose or even a 7th dose if you can get enough into the syringe. The Moderna vials should be up to 10, and they've already cleared and discussed in the ACIP meeting that if someone who's particularly skilled can get more out of it, then they'll allow that. So it can be up to 11 or even 12 if that allows. So those are the key differences. I think, from a 50,000 foot view, I got the Pfizer because the Pfizer was what was available. If Moderna came first, I would have gotten that. I would have not distinguished between the two. But these distribution and storage issues, the allocation, they might be some of the deciding factors as to who gets what. They're both very good and very safe.
Thank you, Dr. Bell. And I think it's also good to know that you have your vaccine, so that's great. Our next question will actually be going to Dr. Munoz, and it will address special populations. Definitely in the nursing community, we have many nurses who are pregnant, they're young mothers. So questions have come up. Is the COVID-19 vaccine safe to be given during pregnancy? And also, is it safe for nursing mothers? And then lastly, can you address, are there any medical conditions that would preclude someone from receiving the vaccine?
Thank you. That's a very good question. First of all, just to be totally clear and transparent, pregnant women were not included in either of the 2 trials. So whatever answer we can give and whatever recommendations have been made by the ACIP, which is the American College of Immunization Practice, and the American College of Obstetrics and Gynecology, they have put out a formal statement on that, are based on good judgment. The main type of vaccine that we do not recommend for pregnant women are live vaccines. For example, like the chickenpox vaccine, varicella, or the measles, mumps, rubella, the MMR. Those are live vaccines, and they're not recommended during pregnancy. The Pfizer vaccine and the Moderna vaccine are not live vaccines. So in general, the general sense is that they should be safe. So the recommendation that has come out is that they're not indicated, because to say that they're indicated, it means that you did a formal study on them, but they're not contraindicated either. And so the recommendation is that any woman who's pregnant but feels that she is at risk for COVID, let's say, could be working in a medical center, work in a setting where there's frequent exposure, that they cannot, that they can get the vaccine if they choose to. They are encouraged to discuss it with their provider, with their physician, and so on. At the same time, it's important to recognize that pregnancy is now recognized as increasing the risk of COVID, of a little bit more severe. Pregnant women are more likely to be admitted to a hospital, before the time for delivery. They're more likely to have premature babies. Not a huge number. We've certainly had a lot of COVID positive women at VCU who have delivered. I'm sure that at UVA, I know the hospitals around the Commonwealth, they have also seen that. And in general, they have done okay, but there is an increased risk. So the answer is that there is no contraindication for the vaccine to be given. It should be thought about, but if a pregnant woman feels that she is at risk for COVID-19, they can definitely get the vaccine. Conditions that make it contraindicated to receive the vaccine, none have been listed. The only complete contraindication to receiving the vaccine is that you have a known allergy to a vaccine, to this vaccines, or to a vaccine component. Which, of course, since nobody has gotten it before, nobody really has allergies to them. But for sure, if let's say you got the first dose of the vaccine and you did have a significant allergic reaction, you should not receive the second dose then. The other contraindication that is, again, it's a soft one, is it's contraindicated to receive the vaccine if you have a chronic condition that your physician says you should not be getting any vaccines at this point. I mean, it could be somebody with being treated for cancer, somebody who's recently received aggressive immune suppression, and so on. But other than that, there really is no contraindication other than allergy to this vaccine and a general contraindication to receiving any type of vaccine. Was there a third part to the question?
Are there any contraindications for women who may be nursing?
The contraindications for nursing are very similar to what I said about the pregnancy. There's no contraindication to receiving it, and again, it is not a live vaccine, so you're not going to be transmitted a live virus to the baby through the breast milk. Just like during pregnancy, you would not be transmitted a live virus to the baby. So in general, there is no contraindication, and I would say, from a theoretical standpoint, the breastfeeding is, to me, is a less tricky question than the pregnancy question. I wouldn't think about it twice, about continuing to breastfeed if for a mom who's breastfeeding.
Thank you, Dr. Munoz. So I'd like to come back to Dr. Oliver. There are questions regarding the allocation tiers. People have been hearing 1A, 1B, what does that mean? And then many nurses, which may be on the line tonight, are wondering, where do they fit into that algorithm?
Thank you for that question, Dr. Gibson. This is a very important question because as we know, the number of doses of the vaccines, both the Pfizer and the Moderna vaccines, is scarce at this point, which means prioritizing who gets it is an absolute necessity. The recommendations coming out of the Advisory Committee for Immunization Practices, ACIP, is what we have been following in this regard. And the recommendations were to do this in a phased manner, phase 1, 2, and 3. Phase 1 being healthcare workers, essential workers, people with chronic medical conditions that put them at higher risk for more morbidity or increased mortality from COVID-19, and vulnerable populations, which would be Black and Brown communities, for example, and people who are elderly without the underlying medical conditions. Phase 2, you start to shift to broader population, and then phase 3, the general public. ACIP broke that down even more, and that's where you got that phase 1A, 1B, 1C definition. They early on defined phase 1A as being healthcare professionals and residents of long-term care facilities, so skilled nursing facilities and assisted living facilities. The nursing community would fall, therefore, in that category of phase 1A as being people who are involved in that direct patient care, and then because of that interaction, being at higher risk for getting COVID-19. And also the idea was that the healthcare professionals is a particular subset of the essential workforce. It's like when you get on the airplane back before COVID, and you were told by the flight attendant that if you had a need for oxygen and the mask came down, put the mask on yourself first before helping others. This is society saying, we're going to put the mask on the healthcare professionals because we want them to be protected so that if we get sick, there's someone there to take care of us. So they were prioritized as number one. The ACIP recommendations they've been done in a way to balance both in these early phases, dealing with some sector of the essential workforce, but also dealing with a population that's at high risk. So in phase 1A, we're doing healthcare professionals and residents of long-term care facilities. This past weekend, ACIP put out recommendations for phase 1B. And in phase 1B, they've expanded to deal with other essential workers. And this group of essential workers they're calling frontline essential workers. So these are essential workers who have interaction with the public. They didn't prioritize them. They talked about police, fire, hazmat, workers in correctional facilities, childcare, K through 12 teachers and staff, certain workers in food and agriculture. If you ever been in a meat packing plant, you know those workers are like shoulder to shoulder, and other some other categories. You can go and check that out on their website. We are taking that list, and we have gone through a process where we're prioritizing that list because we don't have enough vaccine to hit all of those people all at once. If we do all frontline essential workers, and again, they looked at another category of people who are at high risk. In this case, it was people age 75 or older. If we take all frontline essential workers and all persons 75 or older in the Commonwealth of Virginia, that's about 1.5 million people. We don't have enough doses to do all of them at once. So we're in the process of prioritizing those groups that I just outlined. We will then take that to our vaccine advisory work group, have them take a look at it, give us their opinion. This is a broad group that includes medical scientists, faith leaders, community leaders, medical ethicists, and others, and have them vet this list and let us know whether or not they feel it's really an equitable and fair prioritization. We will then take that to our medical advisory committee in our vaccine unit, have them do the same thing, and then from there we'll make the recommendation to the governor about that. So sometime over the next couple to 3 weeks, we will iron out that prioritization. It will take us some time to finish phase 1A. All healthcare professionals and residents of long-term care facilities, that number's about 500,000 in Commonwealth of Virginia. With the number of doses that we're receiving each week from Pfizer and Moderna, we will not be able to complete that until probably mid to late January, unless Pfizer and Moderna crank up the production somehow over the next 3 weeks, which I got my fingers and toes crossed for.
Thank you, Dr. Oliver. So I'd like to go back now to Dr. Munoz to address questions regarding adverse effects. What types of adverse effects are likely to occur from the vaccine? And what are your thoughts regarding some of the press that we've heard regarding allergic reactions? And then number two, if there are any side effects, how would those be treated? And then are we telling people in the community or some of our healthcare workers to avoid non-steroidal drugs to treat those side effects?
Yeah, good questions. In terms of the side effects, I mean, some people do not get any side effects. I got my first dose of vaccine this morning, and my wife had received hers about 4 days ago. She had absolutely no side effects, maybe a little bit of soreness at the arm, and that has been reported. I felt this afternoon like a little bit of like tired, but it might have been for other reasons, but just that has been reported. Some people do get some achiness, just sort of non-specific achiness. Some people have had a fever, typically a low-grade fever, but that's really what was been mostly it. As far as the allergic reactions, there have been reports of not during the trials, but after the vaccines, we started to use in the population. I think the first case was in the United Kingdom, and then there was another one in Alaska. I don't know, all total there have been 2 or 3 cases, significant allergic reactions. No contraindication has been put out about using the vaccine because you have a past history of allergy to other things. The only absolute contraindication is if you've had an allergic reaction to this vaccine or to one of the vaccine products. In general, the recommendation is that if you have had a significant allergic reaction in the past, especially an anaphylactic reaction, is that you wait 15, at least 15, probably more like 30 minutes after your vaccine at the site where you were immunized. And it would also be preferable to be immunized. Make sure that you're immunized in a site that has the ability to provide medical care if necessary. But other than that, there's no absolute contraindication. As far as what to take for any reactions to the vaccine, no clear guidance on that in general. I avoid non-steroidals after a vaccine. You don't know whether reducing the inflammation could in any way interfere with that. My personal recommendation, and again, this is now just me, is that if you do feel a little bit achy or a little bit low-grade fever or something like that, is that you could just take some acetaminophen, some Tylenol. That's probably all that I would do. But there again, there's no contraindication to receiving any other medications. But let's say you're a patient who takes non-steroidals for a rheumatic condition, and that is indicated. You would continue taking the medication. There would be no absolute contraindication to stop it.
Thank you, Dr. Munoz. And Dr. Oliver, we just want to come back to you briefly to ask, after someone receives the COVID-19 vaccine, how are we monitoring them? Is there any follow-up that is required?
Yes. So as Dr. Bell mentioned, if you get the Pfizer vaccine, you got to get your second dose 21 days later. If you get the Moderna vaccine, you got to get the second dose 28 days later. When you get your first dose, you will be entered into the Virginia Immunization Information System, or VIS. So that is our immunization registry. We know from that registry who got what dose of which medication where, and we track that. We also are linked to the CDC's tracking system on these things so that we can reach out and let you know that when and where you should be getting your second dose. We're also encouraging people when they get their first dose to take advantage of some written material that we'll be giving them so that they can keep track of when they need to return. And there's also some phone apps that are available for some to remind people of that. So we will be definitely actively reaching out and ensuring that people get this second dose on time.
Thank you, Dr. Oliver. And I want to remind, I do see people are putting questions in the chat box. Please continue to do that. Dr. Sifry, we want to come back to you. Is there any contraindication for someone receiving the vaccine if they have already been diagnosed with COVID-19?
The short answer is no. You can receive the vaccine if you've had COVID in the past. There was a recommendation which makes sense that you should not get vaccinated if you currently have COVID and are symptomatic. But if you've recovered from COVID, then it's recommended. It should be acknowledged that your chances of having COVID infection within the first 3 months or 90 days after you have a COVID infection are pretty uncommon. It's unlikely, but reinfection has been observed during that period of time as well as afterwards. And so it would make sense that I think if you're in the process, you're getting vaccinated as part of your work, that you take that opportunity, because we really don't know how long immunity lasts to natural infection. It looks like it's probably okay. Pretty good, but there is likely some waning. And, as I said in my introductory discussions, there's probably also the potential for some waning from vaccination. So I would go ahead and get vaccinated.
So let's stay with you, Dr. Sifry. And since we are targeting healthcare providers tonight, what are any recommendations for post-vaccination symptoms in healthcare professionals?
Yeah, and Dr. Munoz talked about this a little bit, I think, which I think that was very good advice. There's not like strong recommendations in terms of what to do other than symptomatic relief with some medications after a vaccine. And I agree. I think using acetaminophen, Tylenol from a biological standpoint also sounds better than trying to dampen an immune response, which potentially could be the issue with NSAIDs, although I think that's a theoretical concern. I think there's a couple other things too. One thing that people may be interested in doing is pre-medicating themselves with medicines to reduce inflammation or other types of symptomatic relief before a vaccine. Again, I think for the same reasons Dr. Munoz talked about, maybe avoiding NSAIDs post-vaccine. I think that is, and it's specifically called out by the CDC, is not a good idea, at least at this point, to pre-medicate yourself before a vaccine. You don't want to dampen your immune response. Like the Shingrix vaccine, if those of you have used that, have received that, or have you seen that in your patients, there is a greater response, or there is a response after getting the vaccine, particularly after the second vaccine, and that's your immune system responding to this spike protein that Dr. Bell talked about, this antigen. And so we want to capture that. That is a marker that we're responding to the vaccine. To me, I think what's most important, that what we've been talking about a lot, is how you schedule your life after vaccination. So I also received my vaccine today, and I'm doing okay so far. No pain or discomfort right now. So I think we're all on the right track. But I think in anticipation of what could occur after the second vaccine, there's been some recommendations which I think are smart, to make sure that maybe that's a day that the day after that, in case you do have side effects, you're not scheduled to work. If you are working in a group and you have a bunch of colleagues, as much as possible, consider spacing out that vaccine schedule over a group, of your team. If you have 10 or 12 people that you work with closely, make sure that you're all not getting vaccinated the same day, so that, if there were to be side effects, especially after the second dose, you're not all feeling the same way after that second dose. So that's what I'd recommend. Mild symptomatic relief, and maybe try to think about what your schedule looks like the day after a vaccine, particularly after the second one.
Thank you, Dr. Sifry. I'd like to go back to you, Dr. Oliver, with a couple of more questions regarding logistics for healthcare providers. How and when will the vaccine arrive to those in private practices, and who will administer those vaccines? Is there a cost for the vaccine? Is there a copay? And then what happens if maybe some of those healthcare professionals do not have insurance? Again, is cost going to be a concern?
As I mentioned, healthcare professionals, whether they're within a large healthcare system or working in the community and private practice, are part of the first phase of 1A of people that we want to get vaccinated. We have a arrangement with the Virginia Hospital Healthcare Association and their member hospital systems, whereby a number of healthcare systems are vaccinating not only their employees, but they are providing vaccination for healthcare professionals in the community. In those areas where the healthcare system is unable to do that, doesn't have the resources or personnel to be able to do that, the local health department is doing that. So there's 23 health departments that are across the state that are doing those vaccinations of healthcare professionals within the community. We have the lists of healthcare professionals that we've gotten from the Department of Healthcare Professionals in the state. We will be reaching out and either from those healthcare systems or from local health departments to do that. It's going slowly, but that's because last week we got 72,000 doses of the Pfizer vaccine. This week we got 146,000 doses of the Moderna vaccine. It's going to take a while to reach everyone, but that's the plan. Over the next month or so, we will reach out to all of those healthcare workers. Also included in that category are EMS professionals. They will be vaccinated in the same time frame. Anyone who receives this vaccine has no out-of-pocket expenses. You won't have to pay a dime to get the vaccine. Medical providers who give you that vaccination can bill your insurance for the administrative costs of providing the vaccine. They will be able to bill Medicaid and Medicare if that's your insurance. And if you are in a situation where you do not have insurance, the Department of Health and Human Services has a provider relief fund that providers can charge their administrative costs to that fund. So bottom line, no out-of-pocket costs for you for receiving the vaccine, and medical providers who give the vaccination can get reimbursed for their administrative costs elsewhere.
Thank you, Dr. Oliver. And we're just at about the end of our targeted questions. And the last question will actually go to Dr. Bell, and it's addressing vaccine hesitancy. What are your thoughts regarding addressing vaccine hesitancy, not only in the general public and with other communities, but also among healthcare professionals? Oh, we can't hear you.
Thank you. Excellent question, as always. And I want to say, the more I think about and talk with people about this, the more I think we need to change the conversation and maybe not use the word hesitancy, because I think having reservation about taking something that's injected into your body is actually a normal thing. Most people are not early adopters. You know, who's standing in the line overnight for an iPhone? Who's trying that new gadget? I don't even like to get new items from the takeout menu because I just know what I know. So I think this notion that, you know, there are people who have some questions and reservation is really normal, and it's on us as a healthcare community to really break through that, but not to make people feel bad that they may have reservation about it, because I think a lot of times the dynamic kind of gets taken to that direction, which isn't helpful. So, you know, with that aside, I think there are different ways to address it, and sometimes it depends on what the underlying issue is. Whenever, like, nurses in the room, we all know that if there's a problem that happens or a report is made about a bad outcome, there's usually a why underneath the initial question that you asked, or the problem that you are trying to solve, and there's usually a deeper why than that. So you keep after asking why till you get to the root cause. Sometimes that root cause is just a simple information gap. So, for example, I saw a Kaiser survey that said among African Americans who either said they probably not or would not get the vaccine, 50% of those people thought that the vaccine would actually give them COVID-19, which is factually incorrect because it only gives you a recipe to make a spike protein, or that it got into your DNA, which is also incorrect because we said it stays in the branch but not into the safe deposit box area. So correcting this misinformation is relatively easy if that's the initial step. There are a lot of people who have reservation about the fact that the vaccine has been able to be produced in a relatively short time frame and has really broken records by about 3 years for the previous record. I think it was a mumps vaccine. Correct me if I'm wrong, Dr. Sifry. But you know, trying to explain the massive investment in government, the fact that it wasn't new technology, that we were able to find efficiencies in the trial approval process, and the 3 independent bodies that normally approve vaccines, namely the data safety review committees for the trials, the Vaccine and Biological Related Products Advisory Committee for the FDA, and ACIP for the CDC. All those mechanisms remained in place. So even though we were able to accelerate this process, the safety really hasn't been cut in any way. And actually, we have more data than we usually do have for vaccine trials. And then we were able to get distribution because we had a lot of doses that were manufactured during the clinical trials process. So allaying concerns around a very real question that, you know, how do you have this so quickly compared to usual case is something that we have to break through. And then, you know, in some communities, and particularly the African American community, that deeper why is a fundamental mistrust of the institutions of healthcare. And what we have to understand is that is an earned distrust. The African American community remembers the injustices that were inflicted upon them by the federal government. And of course, Tuskegee is one of the examples that has been discussed far and wide, but there are several more examples. Patients at the University of Virginia, a lot of them who are still alive today, remember being in the basement of the West Complex in the era when the University of Virginia was propagating the eugenics race theory that advocated for sterilizing Black people against their consent to prevent them from populating and producing more babies and growing in population. And this is a relatively recent memory. Tuskegee ended 11 years before I was born, and patients remember these scars. And so, that's a much harder conversation to bridge those multi-generational wounds. But I think addressing those head on is something that we obviously need to do. And then the conspiracy theories, which your patients, may not even want to bring this up to you because they know they sound crazy, but it's propagating wildly on social media. And they're gaining a lot of traction. So the last time I did, just a cold call, I walked up to 5 security guards in DC and started talking about the vaccine. And I went through that whole spiel I gave you all and asked them if they had any other questions. They said no. And then I said, let's talk about 5G technology and cell phones and Bill Gates and luciferase and all these different things. And they had heard of all of them and started to laugh a little bit, but we actually had to talk about the fact that it's not linked with 5G technology. There are no microchips in the vaccine itself, and none of these conspiracy theories are true, which of course we know is true, but this is what they were thinking about that they did not want to bring up with me. So we just have to be able to meet our patients where they are, address the underlying why, and keep asking out underlying issues. So if there's hesitancy or reservation, that's natural. Find out what the underlying reason is. Now, to talk specifically about healthcare workers, I think one thing that we need to really be cognizant of is that 3/4 of our workforce are made up of women, many of childbearing age, and women of childbearing age or who are pregnant were excluded from the trial. So there are very real concerns around: is it safe for me if I want to get pregnant? Is it safe for me if I am pregnant? Is it safe for me while I'm breastfeeding my baby? And many of these questions, at this point, we have strong feelings and assumptions that it's not going to cause harm. But there's no firm data to kind of back these up. And we're working on that, of course. But a lot of that has to be, first honoring the concern that our workforce has, addressing those issues and referring them to their physicians or society's statements that are all in support of the COVID vaccination, but to make sure that we can address those concerns. So, that's my long-winded sort of answer, but the parting advice is to find the underlying why and to dig deep into the underlying reasons.
Thank you, Dr. Bell. So at this point, I would actually like to turn the questions over to my colleague, Dr. Klein, for anything that has come up in the chat box. Dr. Klein?
Hi, thank you. I just want to take one quick second to thank everyone who is present here, everybody who's attending this session, and above all, I want to thank the panelists, Dr. Gibson, Dr. Bell, Dr. Munoz, Dr. Oliver, and Dr. Sifry for taking the time to help educate our frontline of workers. And we really, really appreciate it. Very quick, and also I want to acknowledge Donald Moore, who is the person behind the scenes. Very quickly, there is a question that has come up here. There was one comment that had to do with mistrust among people of color, and I think, Dr. Bell, you really addressed that very well. I hope that is the case. The question that came up here, that's an interesting one for, I think, people who are managing clinics like Dr. Sifry, Dr. Bell, with only 3 clinic dates spaced 21 to 28 days apart, that does not allow for spacing vaccine administration out. All staff would be vaccinated on the same day. This could be problematic for staffing to meet the care needs of residents and patients. What are your thoughts about staggering those vaccines? What are your recommendations?
Yeah, I'll take a first shot at this and invite others to talk about it. We've thought about it for our workforce, and I consider it like for those of you who work in long-term care, as an example, where a commercial pharmacy like CVS or Walgreens will be coming in to provide your vaccine. They're going to be coming in on certain days. My understanding is that they're going to be selecting 3 dates to come in with the anticipation they'll do groups of, half on each day. So, week 1, then week 3, and then week 6, for example, if it's the Pfizer vaccine. So it is a challenge, I think, in those types of situations, or with a small office that has like 5 or 6 practitioners, to really try to stagger well, depending on where the vaccine access is. So I think it is a bit of do the best that you can. If you have some luxury, you have the ability to have a larger staff where you can space it out a little bit more with more access. I think then I would just try to use that as best possible. I think that's unfortunately the best advice that we have. As this evolves and we have maybe some more products that are easier to give, for example, if there becomes a possibility that we're able to distribute vaccine to, local doctors' offices, or that there's the ability with health departments or health systems and hospitals to provide more frequent vaccine days, then I think those opportunities to schedule may open up more. That's certainly my hope, and something that I'm looking forward to if we can achieve that. But I'd guess that'd be the middle of January or end of January, probably, unless Dr. Oliver feels differently.
Any other thoughts? Okay. Here's a question for Dr. Oliver from a hospice nurse. Hospice nurses like myself visit patients in nursing homes, often exposed to COVID. Where do hospice nurses fall in the allocation tier? The person writing the question said, right now we're at the bottom of the list. Is that correct?
So the bottom of the list for phase 1A. So that's the phase that we're in right now, in which we're vaccinating healthcare professionals and residents of long-term care facilities. So the ACIP list wasn't real granular in that last category. At VDH, we broke it out more. So we're talking about all outpatient workers, oral health, behavioral health, home health workers, or in like this hospice nurse and who's asking these questions, pharmacies, human services, child protective services, when they're going into homes and so on. They're very much patient facing. Mortuary services, public health workers and laboratorians, we'd all put into that group. So our plan is, depending on the supply of the vaccine, is to, while you're at the bottom of that list, that is the list we plan to complete sometime in January. So we will be reaching out to the hospice nurses.
Okay. I don't see any other questions coming in. Please feel free. We have just a couple more minutes. I will throw out a question to the group. Do you want to share any information about additional vaccines that are coming down the pipeline? Any thoughts about Novavax or AstraZeneca, Johnson & Johnson? Where are those in trials?
So I can start because we're looking at that as part of the work group that I'm co-chairing for the Vaccine Advisory Work Group for VDH. So there are some preliminary data that have been released for the AstraZeneca vaccine. You may have heard where there was a 2-dosing regimen, and there was 2 different types of doses for the first shot versus the second shot. And the efficacy overall was about 70%, but there was, interestingly, in the series where a half dose was used for the initial vaccine and then a full dose for the second vaccine, that had about 90% efficacy, very similar to the messenger RNA vaccines. Now, take that with a grain of salt. It's middle analysis, interim analysis. It's not the full weight of analysis. And so I think we're all waiting expectantly for that vaccine information, because it actually has some even easier cold chain issues compared to the Pfizer and the Moderna vaccines. We haven't received information yet from the Johnson & Johnson or for the Novavax vaccines. Those, and I should back up and just say the Novavax it's interesting. It's a protein particle vaccine, which I think some people would find very appealing. And preliminary evidence from like the phase 1 trials was quite encouraging. So I think more to come, and I think we're anticipating we'll get probably a lot of information because these clinical trials, at least some of them are now complete. I think we're going to be getting more information pretty quickly in January.
Thank you so much. We're running out of time. I hope that the nursing community, which is trusted among all patients, will be ambassadors and help to educate our patients. We hope we have answered your questions. VDH is trying as hard as it can to inform the public and educate providers. There will be additional panels in January so that we can continue to reach out. Again, I thank you so much for attending, and thank you to the panelists. Please fill out the survey. The link is in the chat. We would love to hear your feedback so that we know how to proceed and what additional educational programs we should be providing. Sincere thanks to everybody. Thank you, Dr. Gibson, and all the panelists. Dr. Oliver, thank you for taking the time.
Thank you. Good night.
Thanks, everyone.
Good night.
Good night. And happy holidays.
Oh, that too. Safe and happy and healthy.
Yes.
Yes. Stay safe, everybody.